well. So Dr. Zoe Memel pursued her undergraduate degree from Cornell University, where she received her Bachelor's of Science in the Nutritional Sciences. She then went to the University of Southern California for her medical degree, and then pursued her residency in internal medicine at Massachusetts General Hospital. As we know, she's a current third year and chief fellow at UCSF, and she'll be completing her fellowship next June before starting as a staff physician at Sutter Santa Rosa Medical Center. Having gotten to know Zoe well over the past few years, one thing that's for sure is her passion for nutrition and exercise, and I'm so excited to hear her present to us over Grand Rounds. Thanks for joining us, Zoe.
Yeah, thank you so much, Rena. Okay, well, I'm going to try very hard not to speak too quickly. I'm also going to try to make sure that I stay on time. Thank you all for having me. I've been wanting to speak about nutrition to our department for a while, so I'm very honored to have this time slot. I'm just going to dive right in. If people have questions, I recognize nutrition is like a very evolving field that's controversial and everyone has a different opinion and the science is kind of messy. So my goal was to really dive into everything that I've learned through some fellowships that I've pursued that I'll talk about in a second over the past 2 years and really just provide you with more evidence and tools to talk to patients. I'm going to say my opinion on certain things, recognizing that my opinion has changed a million times since I've studied nutrition over the past 15 years. So this is very much an evolving field. So a couple of things that I hope to do today. I'm trying to make this as practical and clinically relevant as possible. I'm not going to go into like the deep science of anything because I just don't have time. But I just want to provide kind of broad strokes, up-to-date insights. In my opinion, every gastroenterologist should be aware of when talking to patients about nutrition and IBD. I'm going to talk about the 5 most common whole food-based dietary therapies for IBD and the pathophysiology and hypothesis behind them, just so you have a better understanding when patients come to you asking about these diets, kind of how do they get created? What's the evidence, basically? And then I'm going to try to provide as many clinically relevant pearls as possible just to keep this high yield. A lot of the slides that I'm talking about, I do have dot phrases that you can steal. I'm going to include a slide at the end with my dot phrases for things like EEN and some of the diets. So that may be helpful to you. Okay, I've been playing with Dolly a little bit. My husband hates this photo, but I thought it was kind of cool. But just to provide a little bit more framework, I have my background in nutrition. During GI fellowship, I have tried to obtain additional nutrition education. So I just wanted to describe what that was in case anyone is interested in pursuing it. So when I was a first year, I completed the Columbia Cornell online obesity medicine course. This allows you to be board eligible for the American Society of Obesity. It's about 50 hours of online lectures and education. I thought it was extremely high yield. Second year, I applied for and was accepted for this new program sponsored by the AGA. It's called the Cedars-Sinai Advanced Dietary IBD Education and Training Program. It was 9 months long, every other week for 4 hours of online didactics, case presentations, got to work with dietitians and physicians from around the world. It was extremely educational. And then I just recently finished the Nestle Nutrition Institute Clinical Nutrition Fellowship. And what that entailed was spending 2 intensive weeks at the Mayo Clinic and then 2 weeks at the University of Louisville, where we had nutrition didactics and kind of hand-on case-based learning for about 8 hours a day, really broadened my understanding of malnutrition, sarcopenia, things like omega-3s, protein, like a lot of things that we just don't get a good foundation in. So if anyone has any questions about these programs, I'm happy to talk to you. One last thing I hope to do before I graduate is I'm now eligible to sit for the National Board of Physician Nutrition Specialists, which I'm going to do this spring. And then there's also this great online fellowship curriculum that's free. It's created by Carolyn Newberry and folks at the University of Rochester. Their GI department is quite strong in nutrition. So this is something you can just find online. I'm hoping to complete these modules as well, just to kind of round out my education. Okay, so as my goal is that as I present this data by the end of this 45 minutes, you will feel more comfortable with seeing this patient in clinic. So this is just an example. I've seen this patient numerous times with various attendings over the past 3 years. So essentially, it's a patient, we can just say they were referred to you for direct colonoscopy for some diarrhea and anemia they've been having. Endoscopically, you find that they have mild to moderate ileocecal ulcers. You biopsy them. They have a new diagnosis of mild Crohn's. They see you in clinic a couple of weeks later. you're thinking maybe you'll start Skyrizi or a biologic. They're very much coming from a perspective of not wanting to start a biologic, and they want to hear, what do you know, doctor, about nutrition-based treatments for Crohn's disease? Tell me what the evidence is. So I'm hoping to give you a little bit more framework, a little bit more background, so you feel confident answering the question. I want to highlight that I had to be very intentional in what I talk about today because there's just too much in nutrition that I've spent 2 years learning that I couldn't talk about at all. This is an awesome expert review that was published last year. I highly encourage you all to read it. I'm not going to be talking extensively about EEN. I'm not going to be talking extensively about TPN or perioperative nutrition, but I do encourage you to look into this review further. Two highlights from the guideline that I just wanted to point out. One is that I do think it should be standard of care now that every patient with inflammatory bowel disease, whether they're flaring or in deep clinical remission, in my opinion, and also supported by the data, should have vitamin D and iron studies checked annually. As someone who has been both iron deficient and vitamin D deficient in the past, I think it's a huge quality of life thing. It improves exercise tolerance and fatigue, and it's something we just know this patient population suffers from. If you have ileal disease or a J pouch, then also B12 should be checked. An example of the prevalence of this is Dr. Beck and I did a retrospective study last year looking at the prevalence of micronutrient deficiencies in our UC population. I think Crohn's disease patients often, we have this concern of micronutrient deficiency, but much less so in UC. So we just wanted to see if it's still an issue. And unsurprisingly, we did find that there was a high percent of patients who were iron deficient, vitamin D deficient, and then thus had significant bone mineral density disease and traumatic fracture. The second point that I'm really just going to gloss over, we could do a whole 4-hour series on this, is exclusive enteral nutrition. So this has been used by surgeons since the 60s, actually, before we really ever had biologics, and it works well. It was first used preoperatively, then we found more and more things, particularly in children, that it helps with clinical remission. But the AGA now, and Europe has been saying this for many years, formally says that exclusive enteral nutrition is an effective therapy for induction of clinical remission in people with Crohn's. I think that adult gastroenterologists really don't feel comfortable with this because we don't get training in it, but it is something that I encourage you all to read more about, talk to our dietitians about, and start to consider when would a patient be appropriate for EEN. What I think is, I'm going to talk about some clinical scenarios in a second, but it's a helpful statistic is that you can achieve steroid-sparing clinical remission rates of about 60 to 80%. That number is mainly from the pediatric literature, but I think more and more data is showing how effective it is. There's also some really interesting data that using EEN with a biologic, for example, infliximab, when you're inducing someone who's flaring pretty severely, can help improve overall outcomes. So another dramatic dolly photo, but what do I mean by EEN as a bridge to therapy? So some patient examples where I think you should consider EEN for like 6 to 8 weeks, for instance, would be preoperatively for a patient with ileocolonic stricturing Crohn's disease. There was a patient I saw with Dr. Chug last year, a guy in his 20s, was getting admitted over and over again for recurrent bowel obstructions, had new diagnosis of ileocrohn's, couldn't really tolerate a diet, had lost a ton of weight. Basically, we started him on EEN for about 6 weeks before he got an ileocolic resection. He gained weight. He did fantastic after the procedure, and there's now robust data that shows that it improves wound healing, flare rate, infection rate. That's a great candidate for someone to go on EEN temporarily. A steroid-sparing agent during an acute flare is another opportunity I think we don't think about enough. For example, in an older adult with brittle diabetes who is having a really bad flare, you start them on steroids, they're really not tolerating it, it's making them delirious. You could consider EEN as you're loading them with infliximab and see if that can kind of help improve their clinical course. Another patient is someone who's just profoundly malnourished. We know the rates of sarcopenia because patients are so catabolic is very high, and adding EEN and kind of guaranteeing that they're getting enough protein and micronutrients as opposed to letting them just kind of coast on Jello and Gatorade for a couple of days, I think it will just improve all outcomes. An interesting area that I think we're starting to understand more but isn't used clinically right now is patients that have intra-abdominal abscesses. They come in, they're fevering. Surgery says the abscesses, there's too many to operate on. IR says they're too small to operate on. You put them on antibiotics. We're holding off on infliximab or steroids, and they can kind of tolerate clears. I think this would be a great opportunity to consider EEN. We can help improve their protein levels, make sure they're getting micronutrients, and possibly improve inflammation. So these are all just some examples. I hope that EEN will continue to evolve with time, but I think that we need to become a little bit more comfortable with it. How does EEN work? I've probably read 10 to 15 review papers, and I cannot tell you the answer. I don't know if anyone can. I think there's a lot of hypothesis on why exclusive enteral nutrition works, but we don't really understand it. There's also a lot of chemicals in EEN, like emulsifiers and artificial sweeteners that I'm hoping to convince you are really bad in a couple minutes. So this is a very interesting topic. Some people think it's because we're reducing dietary antigens, we're breaking down food so it's easier, but I don't have an answer, and a lot of patients ask me this. So what exactly is EEN, and what are the logistics of kind of talking to your patient about it? So exclusive enteral nutrition. There's no evidence to support any one particular product. So when you're talking to a patient about it, it doesn't really matter the brand. Nothing has been found to be superior. We typically recommend starting with a polymeric formula that basically means peptides as opposed to semi-elemental where they're kind of amino acid base. If you've ever tried polymeric versus an elemental formula, the elemental formulas are you're almost unable to drink them. And when I challenge you to try to start thinking about how many calories a patient should have to maintain their weight and how much protein they should have. Just giving patients granular numbers really helps make this more of a reality. So for example, a 150-pound person, about 70 kilograms, they would have to have about 2,000 calories a day to maintain their weight. And about 100 grams of protein a day. The protein is really important, particularly when you're flaring, because it's so catabolic. You really don't want this person to become sarcopenic and have poor wound healing while they're in a flare. So encouraging high protein intake is crucial. Just to give some examples, Ensure is one of the most common oral nutrition supplements that's used. Ensure Complete is the one that I often recommend because it's a higher concentration and you only have to have 6 bottles as opposed to 13. It's also one of the more affordable ones. Kate Farms is another popular one on the West Coast in particular, I think. It's a pea-based protein. And they kind of market as being more digestible and tolerable. And then another thing that I think we need to do a better job in the gastroenterology department is thinking about protein. So whether we're seeing an IBD patient or someone who has severe IBS or someone with gastroparesis, we really don't want this patient population to become sarcopenic and frail. We know that worsens all of their outcomes. So when someone is doing poorly, just using that simple calculation of 1.5 grams per kilogram per day of protein, and then encouraging them to boost their protein intake, sometimes with supplements, I think it's helpful. These are some of my favorites that I recommend. I've personally tried all of these. Fairlife is nice because they use an ultrafiltration process that removes excess lactose. So people who typically can't tolerate a lot of lactose still do pretty well with this. Premier Protein's another easy one. Orgain is a pea-based protein. I don't like the way it tastes, but some people find it to be helpful. And then obviously Fage is probably the healthiest. No artificial sweeteners, no emulsifiers. Okay, I'm not going to talk too much more about EEN. I could talk about this for the full hour, but this is a great paper by Day et al. It goes into kind of the nitty-gritty logistics of initiating EEN. For example, if you are going to induce someone on do induction therapy for EEN, you want to do about 6 to 8 weeks, but they really emphasize that you should be following them at 2, 4, 6, 8-week intervals, and that's why working with a dietitian is so important. This is a dot phrase of everything that I kind of just talked about that I like to include in my patient's after visit summary. It talks a little bit more about EEN. It lays down kind of the brands that I recommend, that proposed mechanism. You do need quite a bit of health literacy for this dot phrase, but I think patients have appreciated it in the past. This is also a dot phrase, just a quick one on the AGA practice update and the micronutrients that I test for. Okay, so we talked briefly about micronutrient testing. We talked briefly about EEN. I knew I kind of flew by that, but I want to dedicate the rest of this talk to talking about whole food-based treatment options for inflammatory bowel disease. These are the five that I'm going to talk about. There are a couple others that I'm not including, like CD treat and a couple other anti-inflammatory diets. But in my clinical practice, I think I've had patients ask me the most questions about these diets. So before I talk about the distinctions of those five diets, I just want to kind of put it all together. How are they similar? What's the main premise here? Dr. Sabino is a physician in Belgium who studies nutrition and IBD. He's published some really great work. He published this meta-analysis in 2019, basically looking at all the different diets for inflammatory bowel disease, what was similar and what was different. The only thing that all the diets had in common was they all encourage fruits, they all encourage vegetables, and they all encourage lean meat. I think this is interesting because I do think historically a lot of patients with inflammatory bowel disease have been told to have a low fiber diet, and clearly the evidence does not show that. So what do they have in common? Lots of fruits and vegetables, reducing oftentimes dairy, refined sugar, and ultra-processed foods. And before we move forward with the diets a little bit more, I really just want to be specific in what we mean by ultra-processed foods, because I think this term is being thrown around a lot, but I want us to fully understand it. And there's a lot of different kind of words associated with ultra-processed foods. So this is the NOVA food classification system. It was created a couple years ago by a doctor in Brazil who was actually studying how the Brazil food system has become so processed so quickly. And there's different stages. You could think about like an olive would be group 1, olive oil would be group 2. The actual substance of olive isn't being manipulated too much, it's just being compressed. But then as you get further into the groups, it becomes less and less of something you can find in nature. Group 4 is what we're going to focus on just for about a minute or two. And these are basically foods that are completely non-natural. You could never find this if you were out foresting in a forest. And more data is showing that this is causing harm to our overall health. I'm going to assume that you guys know that ultra-processed foods, what they are and why they're unhealthy. I'll briefly breeze through two large epidemiologic studies I think you should be aware of. This one had 100,000 patients, 21 countries, 13 years, very robust study, clearly showed that we are eating more processed food, and it is likely associated with why the incidence of Crohn's and ulcerative colitis is increasing worldwide. These are the specific things that they found. They found that processed meat was associated with both UC and Crohn's disease. That was not found in a couple other epidemiologic studies, but the main concepts remain. And then this is another pretty robust observational study that you should be aware of. This was 245,000 patients, also found ultra-processed foods probably contributing to the incidence of Crohn's disease and ulcerative colitis. So what do we mean by ultra-processed foods and additives? I just want to briefly talk about 4 that I talk to patients about to be a little bit more specific on what they should try to avoid. So excess salt, something I honestly don't focus enough on. I also love salt, but adding excess salt to food, if you look at the mouse models, it actually really impairs your microbiome's ability to create these important short chain fatty acids. Butyrate was one that my Nestle Nutrition Fellowship spent a ton of time on because it's so important for the epithelium of the colon, for creating this like thick, healthy mucus layer that you really want to see. And there's pretty good data that having tons of excess salt and synthetic salts really disrupts the microbiome. Another one is artificial sweeteners. So when I was in college, I wrote like a 20-page paper defending artificial sweeteners and how it doesn't cause cancer, and we were all being dramatic. And I will say I've completely changed my tune over the past 10 years just based on the preponderance of data that's now come out. So the World Health Organization last year actually formally now says they do not recommend artificial sweeteners because of all the data showing that it actually doesn't help weight gain, and it may be associated with cardiovascular disease and central adiposity. There's growing evidence that artificial sweeteners really disrupt your microbiome. And I'm specifically talking about Splenda, Equal, Sweet and Low. Stevia and monk fruit, I pretty extensively dived into the data. I couldn't find that they cause clear harm. So I'm still telling patients, I think if they're going to use one, those are the 2 I would choose. But I think more and more evidence is going to show that it's just not worth it to save the calories to use these fake sweeteners, in my opinion. Another one that I've learned a lot more about in the past year is artificial dyes. So specifically red 40 and yellow 6. I included some of my favorite childhood candies that I've had a very large quantity of, but very high in artificial dyes. So red 40 and yellow 6, the two most common synthetic dyes used in the food industry. There's more and more mouse model data showing that these induce colitis in people who have genetic susceptibility. And they're now starting to look at humans, and there's some concerns about cancer risk and things like that. America is a little behind in being concerned about artificial foods and artificial sweeteners. So these are 4 substances that are banned in the European Union that America still allows. What I found interesting is that last year, actually, we voted in California, something called the California Food Safety Act, to ban 4 of these substances. And starting in 2027, actually, these substances will be banned because of the strong data that has been presented. Brominated vegetable oil actually was just banned by the FDA a couple months ago because the data was so strong in regards to thyroid dysfunction. So it's just kind of proving that I do think a lot of the concerns in mouse models are starting to correlate more with human studies. And I think we have to be cautious with all of these artificial additives. A fun fact that I also tell patients is that Whole Foods, Trader Joe's, and Aldi, which are grocery stores, have already committed to avoiding artificial coloring in their food. I now exclusively buy my gummy bears from these stores. So easy things you can do to try to reduce your exposure to processed food. And then the last one, we all know that sugar sweetened beverages is not healthy. Trying to reduce the amount of extra sugar in things like sauces, soups, tomato sauces is an easy way. And just being very specific about how this causes damage, it's probably eroding the colonic mucus layer that is then causing more inflammation to ensue. So we talked about additives. And then the second thing I very briefly want to talk about is emulsifiers. I think you guys have probably heard this come up a little bit more in the IBD world. But what an emulsifier is, the classic example is adding mustard to oil and vinegar. It helps it bind. It's been used in the food industry since about the 1950s to help things last longer, taste better. It's used in a ton of baked goods and ice creams. And more data, the ones that I highlighted here are synthetic emulsifiers, but we are now understanding that they are significantly disrupting our microbiome. This was a study where they took healthy adults, they gave them carboxymethylcellulose. It's the most common emulsifier used in the United States. And then they studied their microbiome. And they found that these patients not only had more bloating and cramping, although you could argue maybe that's just a placebo effect from getting a substance. And then they found over a couple days, I think it was 11 days, that they had decreased short chain fatty acid production. They thinned their mucus layer, and they had a reduction in microbiome diversity. This was another study where they just looked at different emulsifiers and how they affected the microbiome. And they found significant reductions in diversity. The stars are emulsifiers in my favorite ice creams. So I was very sad to see this, but it just further demonstrates how all these specific chemicals, there's more and more data that it's causing harm. The 3 mechanisms that I just want you to remember that perhaps these processed foods are causing harm is they're shifting our microbiome to become more pathogenic. They're disrupting our mucus layer, which is really crucial to preventing bacteria from causing inflammation and just kind of bacterial translocation. And then they may be disrupting these tight junctions that are really important. So all of this is to say, this is why I think we should try to avoid processed foods. But how do we kind of practically talk to patients about this? So in about 30 seconds to a minute, what I just try to say is there's a large amount of data now, epidemiologic, observational, mouse model, that processed foods are harmful. I think that and this is any patient with inflammatory bowel disease that I'm talking to, I think that we should try to focus on at least one meal a day that is mainly from nature, not from a can or box. Try to cook at home as much as possible. I personally just have a blanket statement that I think if you have inflammatory bowel disease, you should be avoiding artificial sweeteners and artificial colors. And I also think you should try to avoid shortcuts, meaning like low-fat, sugar-free options. Trying to choose labels that have 5 foods or less is also helpful. All right, so that was a lot of information. I'm going to keep moving through, and then I'm going to talk about these whole food-based options. So the first one I'm going to talk about that we don't get a lot of exposure to in fellowship is the specific carbohydrate diet. I want you to just understand the historical context a little bit and then kind of what the evidence shows. So it's really interesting history with this diet. So this guy, Dr. Sidney Haas, He was around in the 20s, 50s, 60s. He used something called the banana diet to treat patients with celiac disease before we knew it was due to gluten. He found that patients who mainly ate bananas as their source of carbohydrates got a lot better from their celiac sprue. And he hypothesized this specific carbohydrate diet, basically that complex carbohydrates are terrible for your gut. He was wrong, and he published this in his textbook of celiac disease. He didn't acknowledge gluten. But about 30, 40 years later, there's this woman, Elaine Gottschall. She was a stay-at-home mom. Her daughter had really severe ulcerative colitis. She was told she needed a colectomy or she was going to die. She saw a second opinion and actually found Dr. Haas in New York City when he was 92, and they put her on the specific carbohydrate diet. And the daughter miraculously went into full clinical remission. I'm sure we've all seen a patient who just miraculously went into remission with a specific carbohydrate diet. Elaine was a smart cookie. She then went on to earn her bachelor's in biology, her bachelor's in biology, nutrition biochemistry, and cellular biology. And then she wrote a book called Breaking the Vicious Cycle on the specific carbohydrate diet, how to follow it, her pathophysiologic explanation for it. It was then republished 10 years later, and it has really flourished among patients, not among medical providers. But if you go online, there's like so many Facebook groups, websites, large communities of people who very strongly believe in this diet, and they get very defensive when you say it doesn't work because it works for them. There's only been a couple studies done, kind of like really looking at the patients who've benefited them. This is an internet study that was done about 20 years ago. Out of the 51 patients who agreed to be in this study, 84% in clinical remission with just the diet. Most of them were off all medications, and a few of them were taking steroids. So what is the specific carbohydrate diet? I just want you to be aware of the concept for when you see patients who have it. So basically the premise is that you need to avoid complex carbohydrates. Basically can only have glucose and fructose. And then if you need to break it down with an enzyme like a disaccharidase, it's probably not good for you. Another core principle is that you're avoiding all unprocessed foods. And it's really hard to follow this diet. You can't have dairy unless you make it yourself. You can't have most starch vegetables. You can't have rice. You can't have oats. It's a pretty labor-intensive diet, but people are very committed to it. And the premise is this carb malabsorption causes small bowel injury and then bacterial overgrowth. Most of the studies that have been done to support the specific carbohydrate diet have been in children. Almost all have been retrospective in nature. And there's kind of the two largest retrospective studies I could find were really just looking at clinical remission. Dr. Suskid is a wonderful pediatric gastroenterologist at the University of Washington. He gave quite a few lectures in my nutrition course, and he has published probably the most on this topic. He did the first randomized controlled trial on the specific carbohydrate diet, and he did this in 2020, basically looked at 18 patients, and he randomized them either to the specific carbohydrate diet or something called the modified carbohydrate diet, which I'll talk about in a second, or just kind of a healthy whole foods diet. And then he followed them for 12 weeks. And he did actually look at biochemical response with CRP, ESR, and fecal calprotectin. What the modified specific carbohydrate diet is, and I want you guys to know this because when we're seeing patients with specific carbohydrate diet restrictions, I think we need to start encouraging them to consider switching to the modified diet. It allows you to add in really important sources of prebiotic fiber. So oats, rice, sweet potatoes, nightshades, which get a lot of hatred in the anti-inflammatory community because they have alkaloids in them, although this has never been found to really be harmful in robust studies. And then it also allows wheat. So he compared the modified diet to the specific carbohydrate diet, and he found that they're the same. They have the same outcomes. Anything the modified diet had better normalization of the ESR CRP. Next, a second study I want you guys to know, Jim Lewis at the University of Pennsylvania, he looked at the Mediterranean diet and compared it to the specific carbohydrate diet. Also found that they work just as well. I'm kind of glossing over some big things here, but about 40% of patients in both groups went into symptomatic remission. The fecal cal and the CRP response was not great in either group, and there was no endoscopic findings. But what I want you to take away from these slides is one, we really have no strong evidence on endoscopic remission with this diet. It's only limited to case series, and there's a lot of downsides. One is that this was a survey done a couple years ago. The average patient following this diet spends 10 hours cooking their food. I would say from talking to patients, it's more like 30 hours because they truly make almost everything from scratch. You have to have a very high health literacy to follow this diet, and it's not it kind of ruins your quality of life. You can't really cook, you can't really go out to eat. It's very difficult. It's hard to adapt to different cultures, and studies have shown that these patients tend to be very low in fiber and micronutrients as well. So I do think there are some harms with this diet. These are some resources for people who are on the specific carbohydrate diet that I provide them if they kind of refuse to change their tune, just so that they are at least set up for success as much as possible. But my opinion is that if you see a patient with specific carbohydrate diet, you have to be supportive. The worst thing would be for them to just go off on their own and not follow with a physician. I think that we should tell them the evidence that it's not strong, but if that they're going to continue to pursue this diet, that they get micronutrient testing annually. We're following their fecal calprotectin and CRP. And then I always educate them on the study, two studies. One, the one by Dr. Susskind, saying that you can switch to the modified specific carbohydrate diet. Let yourself eat rice and a couple other foods. And the second study showing you can actually switch to the Mediterranean diet, liberalize your quality of life a little bit more, and the outcomes don't seem different. So I've talked to quite a few patients in clinic about this. I send them the articles. I try to just slowly approach it with them, and I hope it's helpful. Okay, so that's a big topic. We talked about the specific carbohydrate diet, the modified specific carbohydrate diet, and the transition to the Mediterranean diet. I don't recommend this as medical therapy at this time. The next topic I want to talk about is the Crohn's disease exclusion diet. So this was created in Israel about 15 years ago, maybe even longer. And basically, Dr. Levine, Ari Levine, and a registered dietitian, Rotem Segnal-Bonel, created this diet basically with the hypothesis that if we can reduce exposure to things in our diet that are affecting our microbiome negatively, we can improve the outcomes of Crohn's disease without using a biologic. There are three things that he targeted: the microbiome, the intestinal barrier, and the intestinal immunity. And this all kind of stemmed, actually, he's a pediatric gastroenterologist, from his experience using EEN in patients with Crohn's. They did really well with EEN induction. And then once they started adding back real foods, they flared immediately. So he was like, how do I create whole food diet for these kids to go on kind of permanently without them flaring? And it goes back to this kind of pathophysiology of EEN. So the first thing that he did is he knew that the Western diet altered the microbiome, and he kind of very meticulously looked at different foods and what foods would promote good parts of our microbiome and downregulate bad parts. The next thing is he focused specifically on proteobacteria and Firmicutes, which I'll talk about in a second. He tried to pick animal proteins that were lower fat and actually lower taurine, which I don't think has really been supported by the literature. And then he really has a huge emphasis on prebiotic starches. So an example of that is that when you're on this diet, you have to have a potato a day. And he actually asks you to heat the potato and then cool it. And what that does is it creates these resistant starches that are really beneficial to the microbiome. So all this is to say he was pretty intentional with the foods that he chose in this diet. And I think the science does make sense to a degree. He also removed all emulsifiers. So you do have to cook almost everything from scratch or just avoid processed food. And then he removed wheat, carrageenans, processed meat. And he has a pretty large emphasis on fiber. So again, this was a study in the journal Cell. But it just more and more data is showing that if you don't eat fiber, if someone is in a flare and you tell them to avoid all fiber, which is what most people do, it really just disrupts your mucus layer. It disrupts all of these important things and these short chain fatty acids that are so beneficial to the colon. So that is not what he did in his study. There's two pretty big papers that I just want you to be aware of for the Crohn's disease exclusion diet. This one looked at the Crohn's disease exclusion diet plus partial enteral nutrition. I'll explain what that means in a second. And it compared it to kind of the relative gold standard in nutrition therapy, which is EEN. He looked at patients for 12 weeks who had mild to moderate luminal Crohn's disease. His primary outcome was, could they tolerate it? Yes, they could tolerate it. The Crohn's disease diet is definitely doable. Secondary outcome, steroid-free remission. So pretty great steroid-free remission at 12 weeks. So 3 months on this diet, and patients with mild to moderate Crohn's did not need steroids 75% of the time if they were on the Crohn's disease exclusion diet. He also found that they achieved clinical remission, measured by our common PCDAI. He found that they sustained clinical remission at 12 weeks and they had lower CRP. He also looked at the microbiome with the Crohn's disease exclusion diet, being very intentional, again, about avoiding things that harm the microbiome, increasing the kind of beneficial bacteria with prebiotic foods. And unsurprisingly, he found that it did help, and that the EEN patients actually tended to have a negative side effect, which I'm not surprised by. Since 2019, over the past 5 or 6 years, there's been tons of studies done showing that the Crohn's disease exclusion diet is not only helpful in children, but hey, it's helpful in adults as well, and it's tolerated. And then the Lancet, about 2 years ago, they did a pretty big study, randomized control, where they looked at the Crohn's disease exclusion diet with formula, so Modulin was what was used, compared to the Crohn's disease exclusion diet without formula, so just eating whole foods. And they found some important things. So there was about 20 patients in both groups. Clinical remission was the primary outcome at 6 weeks, and about 63% of patients had clinical remission at 6 weeks. So after 6 weeks of just being on this diet, 63% of people felt better. Of those patients who benefited, 80% of them at 6 months were continued to be in clinical remission. And they also, this was the first study to use endoscopy to actually confirm endoscopic remission. And out of the patients who continue to improve, the intention to treat, 35% of patients in the intention to treat group had endoscopic remission, and dietary therapy was able to achieve clinical remission about 50% of patients. So this was a pretty big deal for the Crohn's disease exclusion diet, this study in the Lancet. All right, so I presented you a little bit of evidence. I hope you understand a little bit more of the pathophysiology of this diet. And I want to spend about just 1 minute telling you, like, what is this diet, so that you can have a 30-second elevator pitch if your patient is like, what is the Crohn's disease exclusion diet? I read about it, but how would I actually do it? So it's 3 phases. The first 2 phases are the hardest, 6 weeks each. The first phase is definitely the hardest. It's kind of an induction phase. And there's this list of mandatory foods and then allowed foods. And then PEN stands for partial enteral nutrition. I'll get to that in a second. There's this great website called Modulife. It's sponsored by Nestle, so just disclosing that, but it has really robust patient education resources and handouts. And there is a CDE expert training you can do as a physician. It's free. It's like 3 or 4 hours. I did it. I found it really helpful, and it just prepares you a little bit more to understand this diet. So these are the handouts directly from the website and things that I tell patients. So if you're interested in the Crohn's disease exclusion diet, what will it entail? It will entail that you're going to have chicken breast. They chose this because it's a lean meat that's high in protein and very high digestible protein. You're going to have chicken breast every day. You're also going to have 2 eggs a day. You're going to have potatoes that are peeled, cooked, and cooled, which I know is silly, but we now know it's because of those resistant starches trying to capitalize on prebiotic fibers. And then you're going to have 2 bananas and 1 apple that's peeled. So why the apple and banana? They literally chose that because they are healthy fruits that are affordable and found in every country on this planet, essentially. That's what the dietitian who created this diet said. You're also going to be removing like emulsifiers, artificial sweeteners, colors. You're really trying to kind of reset this microbiome. There's other foods you're allowed to have, but they created this kind of required group just to make sure you're getting enough fiber and protein. And then traditionally, you're supplementing this with about 50% of some type of oral nutrition supplement or formula. But again, I presented that data from 2022 that shows you don't necessarily need to do that. And working with a dietitian, you can just increase your protein with eggs and chicken and not do the formula. So you're doing this for about 6 weeks. Then you move on to the next 6 weeks. You're able to reintroduce more fruits, carbohydrates. The premise here is kind of like you're adding back more FODMAP foods, things that could make you gassy, bloaty, like lentils, rice, some other fruits and vegetables. And then if you continue to do well, you go on to this 3rd phase. What I really like about this diet or this maintenance phase is that once you get past the first 3 months, you're allowed on the weekends to kind of cheat and have these unhealthy foods. They still discourage you from having like processed meat and a lot of emulsifiers, but they're being practical. You know, this was studied in children, a lot of them teenagers, that you need to enjoy life with your friends. And their hope is that you're going to go out and eat poorly for a couple meals on the weekend, but because you're setting your microbiome up for success with these prebiotic fibers, these lean proteins, you're avoiding tons of chemicals that your microbiome can withstand some kind of insults with chemicals a couple times a week and still do well. So that's why they say that on the weekends, you can still kind of have these disallowed foods now. So I think it's a little bit more of a practical diet to follow, although still difficult. A couple notes, there is chicken and eggs. Kind of hard for vegetarians to follow this. If they can eat eggs, it's doable. You have to be willing to cook at home. You have to be willing to grocery shop. It's helpful if your partner or family can join you in this. There is evidence that you want to take a vitamin D or calcium supplement if you're not using formula. And then also, this has not been tested in people with structuring disease. There is quite a bit of fiber that's included. This is a great review that the lead dietitian from the Crohn's disease exclusion diet recently wrote last year. And she basically says these are definitely like strong evidence-based indications, being adults and children with mild to moderate Crohn's, predominantly ileocolonic. And then there's some interesting kind of new pathways that we're looking at. One that I just want to briefly highlight is using the Crohn's disease exclusion diet as a bridge for patients with really severe disease. This was a paper that Dr. Field, Dr. Beck, a couple other people, and I wrote last year for a patient that we all saw in clinic. She was 32, pretty severe medication refractory Crohn's disease. She had tried most of everything available on the market. She was put on UPA 45. When we went down to 30, she flared very significantly. We couldn't capture her back with steroids. So they actually started her on the Crohn's disease exclusion diet. Over 2 years, she did wonderfully. Her fecal calprotectin went down. She went into biochemical remission. She was started on risankizumab. She was able to wean off UPA. She wanted to try to get pregnant at some point, and remain on the Crohn's disease exclusion diet, and went actually into endoscopic remission and has done really well and has continued on this diet. This is a really practical paper on how, as a clinician, you can use the Crohn's disease exclusion diet, when to consider it, when not to consider it, and also actually how to counsel patients who are in the maintenance phase, how to go back to the restrictive phase when they're having a flare. So again, kind of using it as like a steroid sparing strategy. And that's what our patient who was in that case report did. And it works really well for her. She continues to be on this diet. So again, recognize that was a lot of information. I have a pretty robust dot phrase that I've created on the Crohn's disease exclusion diet that I have here in case you're interested. This kind of just introduces the diet to the patient, provides some handouts and some more education. All right, so we talked about the specific carbohydrate diet, modified specific carbohydrate diet, the Mediterranean diet, and then we just introduced the Crohn's disease exclusion diet. The AGA clinical practice update now formally says that they recommend this as an option for mild to moderate luminal Crohn's disease in adults and children, and possibly for refractory disease, although I think the data is not strong enough yet. It's more of like an expert opinion at academic medical centers at this time. I want to just briefly mention this diet, although I'm not going to have enough time to go into the nitty-gritty. The anti-inflammatory diet, in case a patient ever asks you about it, was created by a group at UMass Chan Medical School, and they took the specific carbohydrate diet and they basically tried to make it better. They added more probiotics, prebiotics, and they continued to eliminate a lot of processed foods. It has really no robust evidence, and I don't recommend it, but I do think they have a really great emphasis on texture modification, and they have a great website on the emphasis of not avoiding fiber. And we really shouldn't be telling patients to avoid fiber, but to modify their fiber. And they have a lot of resources on what that means. So I just wanted to kind of share that. I looked pretty deeply into the literature. There's no strong evidence that this works. There's some symptomatic and clinical remission data, very small sample size, and I would not recommend this diet. So lastly, the diet that I think we all feel the most comfortable with and have been hammered on since medical school is the Mediterranean diet. So what does the AGA clinical practice update say? So they formally say all patients with IBD should be advised to follow a Mediterranean diet rich in fruits and vegetables, monounsaturated fats, complex carbs, lean proteins, and low and ultra processed foods. Again, getting into my opinion that we should spend that 30 seconds counseling patients on avoiding ultra processed foods. Marion Nessel, one of my favorites at NYU, she's a professor of nutrition. She basically acknowledges that we throw this term, and I also kind of get annoyed by this, that we throw this term, the Mediterranean diet, around a lot, but what does it actually mean? It's basically just eating a lot of plants, balancing calories, not eating a lot of junk food. So I like to use the term just plant-based or whole food-based diet as opposed to Mediterranean diet, because I think some people are less familiar with what exactly that means. I'm not going to spend a lot of time convincing you that the Mediterranean diet is healthy. There is a ton of evidence showing that it's helpful in IBD as well as many other diseases. There's also some interesting evidence that it may help with pouchitis, but I don't have too much time to get into that. 3 key concepts. Again, this is going back to the same concepts of the Crohn's disease exclusion diet. This is a recurring theme in the GI nutrition IBD space. You can improve the gut microbiome by more healthy fibers. You can reduce inflammation by avoiding those chemicals and creating more short chain fatty acids. And you can protect this coveted mucus layer, which we're going to talk a little bit more about. This was a great paper by a dietitian named Godney, where she basically says that the Mediterranean diet we shouldn't only be counseling patients who already have IBD, but it really spans the life cycle. So she found in this review that patients actually, first degree relatives of patients with inflammatory bowel disease who follow a Mediterranean diet, they're found to have decreased fecal calprotectin, improved microbial diversity, improved short chain fatty acids. So it's something really the whole family should be following if you have a genetic predisposition. Once you have inflammatory bowel disease, it helps reduce your risk of flare, lowers your fecal calprotectin, and can help you go into a deeper remission, and just overall improves your quality of life. I thought this was a cool study where Godney's group, again from Israel, followed healthy adults for 4 weeks, and she was able to specifically isolate foods that were associated with less inflammation. And unsurprisingly, the more fruits and vegetables and beans that you can eat, the more foods that are high in omega-3 fatty acids improved your microbiome. I'm mainly going to focus in regards to the Mediterranean diet, just for the last couple minutes, on some helpful resources and terminology that I think you should use with patients, because I'm assuming that you all know some of kind of the basics of the Mediterranean diet. These are 2 great papers. Dr. Mahadevid was one of the authors of this first one, the IOIBD from 2020. And the second one is a great paper from Alexa Sasson that just kind of describes all of the evidence on the Mediterranean diet. But I really like this food pyramid. I think it's way better than like the traditional cartoon that we sometimes show patients, because it's very granular and specific on what you should be eating, with the foundation being fruits and vegetables, and then emphasizing a lot of legumes and reducing processed foods yet again. I've included this in my dot phrase and all of my handouts because I think it's helpful for patients. I say, hey, you could print this and put this on your refrigerator. Just again, trying to be as specific and focused as possible when talking about nutrition recommendations. So how do we counsel these patients? I give them my spiel on processed foods. I name specific agents I personally think that they should try to limit as much as possible. And then we focus a little bit on fruits and vegetables briefly. So the data shows that trying to eat as many fruits and vegetables is helpful. I recognize a lot of people have intolerances. So what I say is try to pick one. I really like this 1, 2, 3 rule that a couple dietitians have taught me, but basically 1 fruit or vegetable with breakfast, at least 2 with lunch, and 3 with dinner. You can change that formulation, but being very specific in your goals. Trying to cook at home as much as possible and to try to avoid these artificial ingredients. Speaking about fiber, the amount of patients who I've talked to either with Crohn's, ulcerative colitis, or just varying GI diseases who have been told to avoid fiber for the rest of their life, I'm very surprised in 2024. But I focus on texture modification. So I tell them even when they're in a flare, they should be eating fiber, and we just need to modify the type of fiber. So I have a handout with these fibrous foods that are soft and gentle and shouldn't cause GI upset. Avocado is a really good one. Nut butters are helpful. Oats, hummus, these are all things that are much softer and shouldn't cause as many problems. The reason I emphasize this so much is because there's so much data showing that if you deprive someone of fiber, if you tell a patient with Crohn's disease to stop eating fiber, you're actually harming them much more in the long term, because you need those prebiotics to create short chain fatty acids and protect this mucus layer, which is so important. So again, I think more and more the data is showing we need to tell our patients to eat fruits and vegetables. And I like this slide that says, stop thinking about fiber and start thinking about roughage. So again, just trying to modify things, except for obviously patients with stricturing or obstructive disease. So lastly, in the next couple minutes, I just want to give a couple more resources. 2 foundations that I mentioned to everyone, just so that they're aware and have all the tools that they can at their skill set. So the Crohn's and Colitis Foundation, I think about 2 years ago, launched this awesome recipe platform that was supported by a grant. And basically they can go on and type in and filter by different types of diet. So the Mediterranean diet, the specific carbohydrate diet, the Crohn's disease exclusion diet, and there's tons of great resources. This was all created by a GI dietitian who specializes in IBD. This website, Nutrition Therapy for IBD, I also strongly recommend to patients. This was actually created by a family member of a patient with Crohn's disease. It's really nice because it filters by specific dietary therapy, and all of these have been vetted by dietitians as well. And then I try to be as very specific as possible and to give cookbooks, recipes, websites. I think we have to set our patients up for success by giving examples. So these are 4 books that I've actually all looked at myself that I like. I think they're practical. Some of them are more affordable, some are a little bit fancier, but they all are easy ways to start incorporating more Mediterranean-based, or what I say plant-based dietary approaches into their lifestyle. So all of this again is summarized in a dot phrase that I have that you're welcome to steal, but I think the emphasis should be on spending 2 to 3 minutes with every patient and trying to be granular and specific in some goals that they can achieve. All right, so just to briefly summarize, we talked about 5 whole food-based treatment options. If you see a patient on the specific carbohydrate diet, I think you need to recognize that they probably got there because they've had a really tough time and some adverse experiences with the medical system that have led them to that diet. Maybe not, but that's been in my experience. I educate them on that strong randomized control trial that showed that they could probably liberalize to the modified specific carbohydrate diet and do just fine, get some more fiber. And then I educate them that they could actually probably slowly move towards the Mediterranean diet based on the DINE CD study, and that I kind of phrase that more as a whole food, plant-focused diet. I think we need to think about the Crohn's disease exclusion diet as in our armamentarium for treatment, particularly for that patient I introduced at the beginning with mild to moderate Crohn's who's very motivated and interested in dietary therapy. I do think this is a feasible and efficacious option that we now have available to us. And also in the future, I think we're going to be using it more for medication refractory disease. I think every patient, we should spend a couple minutes on just telling them the data on whole food plant-based diets. And then lastly, I don't think there's enough data to support the autoimmune diet, but I do think that their resources on texture modification are really helpful. I kind of summarized most of this. I didn't get to talk a lot about protein. That could be a whole different talk. But I will say I've learned so much about protein in the past year that I think we need to emphasize more that when a patient is flaring, they're hypercatabolic, and they really should be trying to get enough protein, which I think is 1.5 to 2 grams per kilogram per day. That's what the AGA recommends. All right. And then lastly, I think all of our patients should be referred to Neha Shah, who's our wonderful dietitian here. If you're worried about a patient or you want to kind of quickly start them on EEN therapy, you can always message her. If she feels like she can't see them quickly, this is just an additional list of dietitians I've personally worked with or have gotten very good recommendations from. They all have significant expertise in inflammatory bowel disease and nutrition, so I'm just listing their resources. I also have a dot phrase for them as well. And then this is just a summary of the dot phrases that I talked about today. All right, well, thank you so much. And I have 5 minutes to spare, so I did it.